Okay, Bismillah ar-Rahman ar-Rahim.
Wait. I will. Just wait. Okay, so first, okay, hello everybody. Thank you for joining. We will start. So today our speaker is Dr. Ahmed Dana. He is a consultant neonatologist. He is also associate professor of neonatology. He's very eager neonatologist, very knowledgeable, very hard worker. I have privilege to work with him. I think he has a great future. He loves ventilation and play with computers, and I'm sure we will get lots of knowledge from him. And so please, Dr. Ahmed, start your presentation. I will mute myself and I will control the room. Go ahead.
Bismillah ar-Rahman ar-Rahim. First of all, I want to thank my teacher, really, Dr. Yahya. It was really a great opportunity to work with him for almost a year or so. We learned a lot of them, and part of it actually the neonatal pulmonary graphics. So I'm going to talk today about the basics mainly. It can help, but it can help a lot our people, especially the junior doctors who are present during the on-calls and dealing with the ventilator with our sick babies. So first of all, what is the importance of the graphics? The main issue of the graphics is to have a proper ventilation function, and of course later on initiation of the weaning process. So by understanding the graphics, you will learn a lot of it. Now we need to understand something. Before, what we used to do, we just put the baby on the ventilator and we don't know what's going on. We are checking just the oxygen and the blood gas. Now, the problem that we don't know what happens with the baby. So you are putting him on something which is unusual, which is non-physiologic. You know, you put the baby on the machine, but you don't know what's going on. So the beauty of the graphics actually, which started actually the booming of it in the early 90s, is to understand what's going on between the baby and the ventilator. And this is, of course, depend a lot on the disease process, what's happening in the baby's lung. So by understanding this sort of interaction, you understand a lot of what's going on. So it's like another monitor for you. It's not like just the simple oxygen saturation and CO2, which you get it from the blood gas, but you learn a lot from those graphics. So by understanding that, you know how to deal with the function of the ventilator, and of course, the fine tuning. So by understanding what's going on, then if the baby is not happy with the ventilator, then you can adjust the settings. So you decrease the work of breathe and you can maximize the patient comfort. And of course, the fine tuning to get the optimum ventilation function. Of course, if the baby is getting some therapy, we are going to talk about especially asthmatic patient, where you put the baby on a bronchodilator, you will see a real response with the graphics. Actually, it's like a pulmonary function test, but you do it in another way with the graphics. You pick up problems which usually the nurses used to do it like in a routine care. No, there is nothing called routine care. You need to do it once it is once you see it with the graphics. So if you have secretions, if you have leak, you need to adjust the position of the ET tube, or in case of emergency situation, for example, if there is a tube displacement, also you can pick it up from the graphics. I'm going to talk about it because this is very important. So as we said in the beginning, so you understand the respiratory disease and what's going on from the graphics. So are you dealing with airway resistance, or you have a problem with the lung compliance? So, and this is really important. So you understand the disease process. And of course, from the beginning, when you are setting the baby on the ventilator, you need to have a history to understand what you are going to put the baby on, because the settings depend mainly on the disease process. So let's, for example, for a lung compliance, you need, if in case of hyaline membrane disease, so a preterm baby who's born with surfactant deficiency, they will have poor lung compliance. We will, so let us give an example. So if you have a balloon, and this balloon, one is the new, another one is old balloon. Let's give an example like that. So the balloon which is stepped means that it is a new balloon, a poor compliance lung. When you try to inflate it, you have to generate a high pressure to open up this balloon. So this is the issue. If you have a poor compliance, mean restrictive, what we call restrictive lung disease in case of surfactant deficiency. For example, here, the new balloon, when you are trying to open it, you give a lot of pressure to generate little bit of volume to inflate the balloon. Okay. Now, if you get an old balloon, means a good compliance lung, when you just give a simple inflation, you can open it easily. Means little bit of pressure gives high volume. So this is the compliance, just to understand what does it mean, the lung compliance. Now, the resistance is a different story. Resistance, let us say the same, you got a balloon, but with a big neck, or a balloon with a small neck. You know, those balloons which, you know, they play with it, try to do shapes. This is the small neck balloon or the bigger neck balloon. So, of course, the small neck balloon, you need to generate a lot of pressure to overcome this resistance, which is in the real life is the airway, the resistance which is happening in the airway. So the flow of this high resistance, you need a high pressure to overcome this resistance so you can generate the flow. Okay, so of course, on vice versa, if you have a big neck balloon, it's very easy because you don't have that much resistance, so the airflow will be much better. So the resistance is the relation of the pressure to the flow. The compliance is the relation of the pressure to the volume. So this is in a simple understanding. So the example of the airway resistance is in case like of bronchial asthma in children, and in the newborn baby, the best example is meconium aspiration syndrome. Now, this is just to understand the importance of the graphics. Now, the graphics has two types, either it is waves or loops. Now, we have three parameters. So the machine, the ventilator can measure three things. Can measure the flow, can measure the pressure, and can measure the time. Of course, there is one more measure, is the volume. Now, if you have the pressure, flow, or volume over time, this is, you are talking about a wave. Okay, so if there's pressure over time, there is a flow over time, and there is a volume over time. So to understand that this is, when you are talking about waveforms, you are talking about those three variables, pressure or flow or volume over time. When you are relating those parameters together, you are talking about loop. So either it is pressure over volume loop or flow over volume loop. So we will get through. Before digging into the graphics, we need to have an understanding of the ventilator, how it works. So this is a simple diagram. So what's happening? You are taking the air and the oxygen from the wall, from the medical gas, you take it, you make a reservoir. So here is your mixture or your blender, okay, and there is a flow of this gas. This flow of gas, of course, it will go to the ventilator, and this is the humidifier, the tubings, and this is the patient, and this is your flow sensor here. So what's happening? The airflow will come in with the mixture. Of course, you decide here what is your FiO2. Then this mixture of air, the blended air, it will come here. Now, the work of the ventilator, the job of the ventilator is to generate pressure. So it will compress this air to generate pressure. So this is the function of the ventilator. Now, so the aim, and this is very important. So the aim of the ventilator is to generate pressure. So if there is a problem that the ventilator is not generating the pressure, is not able to generate, means there is some disconnection here, which is usually before the patient. So the air is coming, and there will be a control here to get the PEEP. So the air is flowing. Now, if you want to generate PIP, you close the exhale valve. You just close it. So the PIP the pressure will increase as a positive inspirated pressure. The air will go through the humidifier and to the patient. Now, once the patient is, once we open up the circuit for expiration, the pressure will drop. So the air will come back from the patient out. So this is what happened. Now the airflow in or out is getting by, you got it by the flow sensor. And so the flow or the volume here, you got it flow over time, you got the volume. So the volume, you got it through the flow sensor. So this is a simple understanding. Now, so how did ventilation work? It has 3 phases. So for any, let us say, a breath circuit, means inspiration and expiration, a breath cycle, sorry. For inspiration and expiration, you start by the trigger. So something will trigger the machine to generate the pressure. Then the pressure will go up at certain time, which we call it the rise time. Then it will reach a limit, which our target, okay? And it will stay for some time, this to open up the lung, to recruit the lung, to initiate the ventilation. Then there is a time when what we call it the cycling, means the stopping of the inspiration. So this is, as we said in the previous slide, here when you open the exhalation valve. So this cycling or stopping of the ventilation, this is the time you initiate the expiration. It can be a time cycle or flow cycle. So the initiation, again, the initiation we call the trigger. It can be machine controlled fully, especially if the patient is paralyzed, or it can be assisted, means that the patient will initiate, will trigger the ventilation, and the ventilation will synchronize with the patient to initiate the inspiration. The target here, it can be pressure, it can be volume, and the cycle, as we said, can be time and we can be flow. So this is the I time. Then this is the inspiratory time till you initiate the expiration. Now, to understand that, so the as we said, now the types of breathing, it can be assisted, means that the patient will generate some flow or pressure. In neonates, we prefer to use the flow trigger because the baby is doesn't have that much volume, so we need to have a flow trigger. So we start to initiate, then the machine will, as we said, will synchronize with the patient and will assist him. In control, there is nothing, so the patient, the machine will do it independently from the patient. Okay, so these are the triggers. Then the rise time. So this is from the till you reach the plateau. So there are 3 types of rise time. Either you want it slow, or you want it moderate, or you want it fast. Now, in slow rise time, the problem that you don't have much time later to get to the plateau pressure, so you can generate much tidal volume. So if you have very slow rise time, you have less time for to get the tidal volume, and of course it will less inflate the lung, and on the long run it will cause problem with the lungs. It will initiate injury. Now again, if you do it very fast, you will see overshooting here. Okay, so when you have an overshooting in the pressure here, means that it is very fast, and this is of course means that you are stretching the alveoli very fast, and this will cause again damage. So the best thing is to select a moderate rise time that will give good time for the eye time, and at the same time it will not cause fast rise to initiate injury, to cause injury to the lungs. Okay, so this is again, so this is the proper rise time, because it goes up smoothly. It gives good time for the inspiration. But here, if there is no good time for inspiration, it will go and there is no time to complete it. One more thing here to have to keep in mind. Sometimes there are some machines where you need to, as we mentioned initially, to generate a pressure in the machine, you have to have a good flow. Now, some machines, the flow of the ventilator, the flow of gas in the ventilator, you need to set it yourself. It's not automatically set. So you need to set it in a proper flow, so that machine will generate pressure. If you don't have air inside, it will not generate pressure. So then it will appear again like this. So there is no air to get the pressure in. So this is another way to see it. So if you have a steep like this, a triangular shape in this waveform, which we call it the pressure waveform, if you don't have, if you have it in this shape, this means that either a very slow rise time, or it can be low flow. Then another important point we need to understand. So always there is a question, what sort of eye time I need to set to the baby, to a small baby? Is it 0.4? Is it 0.35? Is it 0.3? Is it 0.5? So actually there is a calculation which can help you, and this is of course the machine will give you this feedback. So from whatever is happening inside the machine, you will get it as a feedback. So this is, we call it the time constant. So the I time is usually around a 3-time constant. So how to calculate the time constant? The time constant is the compliance multiplied by the resistance. So if you have low compliance, means like RDS, highly membrane disease, for example, you don't need long I time, you need short I time. Again, so if you have poor compliance, baby, low compliance, then you have a less time constant. Less time constant means less I time. Let us give another example. So the resistance. If you have high resistance, let us say the tube is kinked, there are some secretions. Increasing in the resistance, this means that you need increasing in the time constant, this means that you will need higher I time. Okay? So, and this is the way the ventilation is getting the compliance from the interaction between the delta P and the delta V, and the resistance between the delta P and the flow. Then cycling. So all we are talking about the basics of the ventilation. Understanding the basics, then you understand the graphics. So again, the cycling is the time you open the expiratory valve. This is the time you initiate expiration. We said that it is either time cycle. So when you put it as a time cycle, in all assisted control ventilation means like SIMV, SIPPV, CMV. So all the ventilator, all the ventilation, all modes of ventilation, which depend on the ventilator. So the ventilator is determining everything you talk, it will be by the I time. So the machine itself is the one indicating what sort of I time we will give. And this is, of course, will be done by the doctor. So we are setting the I time. So this is dependent on the machine. Now, in case of flow cycling is somehow determined by the patient. So when you do it, what does it mean determined by the baby? Because it depends mainly on the interaction between the ventilation and the lungs, and according to the pathophysiology of the disease itself. But here again, you set it at certain levels. So what does it mean, flow cycling? Means that this is the inspiratory flow, and this is when it is rising, and this is when it is coming down. So when the flow is coming up, this is we reach the plateau, then you don't need that much pressure. So that much flow will start to drop. We set the machine, let us say you start the exhalation when you reach 30% of this flow. You want to initiate it at 50%. So this is, of course, depends on the patient himself, how much you want to give him time. Now, if you give him very low, let us say at 5% flow, means that you don't, you are like suffocating the baby. He wants to start exhaling and you are still giving him the flow. So this doesn't work. And if you give him very high, again, as if you don't give him much time to give the tidal volume. So you need to select something in between. Usually at 30%, 20 to 30% is a good time. And this is the flow cycling. It's done in case of pressure support ventilation. So in PSV mode of ventilation, you use the flow cycling. I don't know if I'm going fast, if somebody is not understanding, please let me, you can stop me because...
Ahmed, can you repeat what's the meaning of the flow cycling? What's the difference between flow cycling and triggering? I think maybe people are a little bit confused. So can you
Okay.
repeat that, please?
Okay. So going back to this diagram. So there are, as we said, the trigger is the starting of the inspiration. The limit is when the machine will stop giving the flow of, will start to stop the flow of air. And this is because you reach the target, either pressure or volume. And this is the cycling means the time you open the exhalation valve to start the expiration. Now, this from A to C is the I time. So at cycling means when you stop you open the exhalation pressure here, you start the expiration. Okay, this is either by time, so you just set the I time here, or it can be by flow cycling. So when you set the I time in ventilation modes like is a continuous mandatory ventilation CMV, when you put it on SIPPV or SIMV. So in those modes, you put it as a time cycle. So you open the valve when you finish this I time. But in pressure support ventilation, we give the chance to the baby himself in a way according to his the lung pathology. So it will be as a flow cycle, means that when, as we said here, so when you reach, we tell the ventilation to open up when he reach 30% of the flow, let's say. So according to the dynamics between the ventilator and the lung of the baby, at 30% of flow of air inside the lung, when we reach it, the exhalation valve will open.
So I'm going to interrupt you here. So yes, the patient is going up to the maximum flow, which is 100%, and then he's going down to 0. Once he reaches 30% before the 0, you open up the exhalation valve.
Exactly.
Okay, understood. Thank you very much.
So this is again the inspiratory cycle of. So this is the cycling. So here, if we select 60%, as we said before, if we select the 60%, this means that you lose volume because you didn't give time to inflate the lung. So here you lose the volume. And if you set it very low, let us say 5–10%, here the baby wants to exhalate, but you didn't give him time, you didn't open the valve. So here you will see an exhalation spike. So the baby start to exhale, but you didn't open the valve. So you don't want very low flow cycling. You don't want very high flow cycling. And this is, again, we use it in pressure support ventilator. In a way, the baby is driving the machine. Now we will start the graphics. Now, to understand the graphics. So we said there are 3 variables: the pressure, the flow, and the volume to the time. Okay? So the pressure, always it is above 0. So this is the peak. Then this is the time, the initiation of the ventilation, the inspiration. As we said, this is the trigger. Is it controlled or is it assisted? Go up till you reach your limit. Then you go to the plateau. Then the time you open up the exhalation valve, so the pressure will drop to go back to the peak. So this is the pressure wave. Now the flow waveform. So this is the air which is going in the inspiratory time. So it starts from 0 and ends by 0, because this is the flow of air going across the, this is, as we said, it is measured in the flow sensor. Okay, so the air will start going inside the baby, and the inspiratory time will go up. Then the flow, of course, will be reduced when you reach the peak. It will start to go down till the I time or the flow cycling will end. So it starts from 0 and end up by 0. When you open the exhalation valve, now the air is flowing out of the flow sensor, out from the lungs, out from the baby. So there will be, it will be in negative. So the air is going out. So it will come also very fast. Then slowly, it will reduce till you reach the end when the air stops coming out. So this is the expiration. So, so again, it starts by 0 and end by 0 in the inspiratory time. So this is the inspiratory time. And in expiration, it starts from 0 and end up by 0 again. Just to understand, so the volume, the area under the curve here is the volume during the inspiration. It should be equal to the area under the curve in the expiratory time. So this volume is equal this volume. If there is a leak, so this area will be less than this area, or this area will be bigger than this one, just to understand it. Now this is the volume curve. So the volume will go up and it will show some slope here. Then when the volume is coming out from the lung, it will go down till it is ending. So it starts by 0 and ends up by 0, always positive. Okay, so these are the pressure. This is the waveforms. Now, there is something very important to understand in the pressure time waveform. So the area under the curve here is representing the map, okay? The mean airway pressure. So we know that if you want to increase the oxygenation, part of it is to increase the map. So how to increase the map here? So here, let's go to this diagram to make it easier. So this means that if you want to increase the map, you do certain steps here, so you achieve your map. So either by making the rise time more steeper, you increase the PIP, you increase the inspiratory time, okay, increasing the PEEP, or shorten up the expiration. So all of these, if you understand it, then you understand how to increase the map. Increasing the map in this diagram means that you can increase the oxygenation. It helps up in recruiting the lung. Okay, so 5 steps or 5 ways. The main thing which we know is increasing the PEEP, but it can be done also by increasing the PIP, increasing the I time, decreasing the E time, or make the rise time more sharp. Now going to the flow waveform. So the flow waveform, as we said, here this is the peak inspiratory flow, and this is the peak expiratory flow. So when the flow of air going up, then till reach the plateau, then it will go down till reach 0. Then when the exhalation will open, the air will goes out in maximum flow till it reach the peak flow, peak expiratory flow. Then it will go back slowly till reach 0. So this is the inspiratory time, and this is the expiratory time. So this will help, this graph will help if there is a leak, if there is air trapping, if there is increase in the resistance or there is an obstruction. This graph will help you in that. We'll come back to it. So as we said, the area under the curve in the flow waveform equals to the volume. So if it is both equal, in the inspiratory and in the expiratory, so this means that there is no leak. Now, as we said, the inspiratory flow, it should start from 0 and end up by 0. Now, there is a situation, it should end up expectedly before 0, which is in case of the pressure support. Why? Because it's a flow cycling. So we are setting the ventilator to end up early. So the inspiratory time will end up early. So this is the only situation that the inspiratory time will end up before reaching 0. Now there are situations that the I time is not completed, means that it is not reaching the 0 level. Either it is too short, means you are not giving the needed I time because the baby is having good compliance, especially after improving of the lung condition, or there is high resistance. So this means that this short I time. There is another problem if you have too much space. So this I time usually should reach the 0 and just a little bit, then go down to the expiration. Now, if it is very long, this is again not proper. Why? Because you are working against the baby. The baby wants to exhale, but you are not allowing him. You are keeping still the ventilation in the inspiration. So then when it is too long inspiratory time, again, it's not proper. So the third point in the expiration. So if the expiration is not reaching 0, okay, I will explain it. This can cause air trapping, okay, and if it is reaching but it takes long time, means there is some obstruction. So these are the important things. So if the flow waveform is doing what, if there is no problem with it, this means that no leak, you are giving proper I time, and no trapping, no obstruction. Now, in the volume waveform, so as we said, this is the inspiration, the volume will go up, okay, till reach the plateau. Then with the expiration, till the inspiratory time will finish. So this is the inspiratory time. And this is the expiratory time when the exhalation valve will open. So the expiration will go. So this is the way it looks like. So it will start sharp, then there will be a little bit of slope, then it will go down smoothly, which is usually a passive process. So the lung itself, the recoil of the lung, the recoil of the chest, this will allow the expiration. So what is the importance of the volume waveform? So it helps to check for air leak. We'll get up to the examples on how it looks like. So it will show up if the pressure which you give it, it's achieving the volume you want. Assess the impact of various changes in the ventilatory settings on the volume delivery, and assess the patient ability to generate adequate volume. So this is how it helps the volume waveform. So now we finished with the waveforms. We will go to the loops. again, just this is, I'm trying to give the basics initially, then we will go to the examples and the clinical application. So the loop, as we said, you have three variables, is the pressure, the volume, and the flow. So if you join the pressure to volume flow, the pressure in the X and the volume in the Y, if you join them together, so you get a loop. So the loop starts as a pressure. It starts from the peak. You don't start from zero, you start from the peak. It will go up, so that you initiate the pressure till you open up. Usually we call it, this is the opening pressure, till the lungs start to open. So initially you give very high pressure to open the lung. Then when you reach the opening pressure, little bit of pressure will generate the volume. Now, till you reach the maximum opening pressure, after that, you don't generate much volume with the increasing of the pressure. So this is the peak inspiratory pressure. Then when you go back with the expiration, till you reach the closing pressure, so when the lung will when the alveoli will close and the air will come out. So it will be in this way. So the line between the inspiration and the PEEP here is the compliance. And the area here is the resistance. So this is again explaining the same thing. This is whenever there is a deflection like this means that this is a trigger. So the baby is starting the ventilation, then the machine will start by the inspiration, initially high pressure to open up, then less pressure generates more volume. So till you reach the PIP, the PIP. Then go back again till you reach the closing pressure. So the volume will fall fast to reach to the peak. So this is the relationship here between the volume and the pressure. You get the complex curve. This is very important. So from this pressure volume loop, you deal with the complex. And as we said, the importance of the pressure volume loop, it helps to determine if there is lung overdistension, airway obstruction, bronchodilator response, respiratory mechanics, work of breath, flow starvation, leak, and triggering effort. So this is just, I'm enumerating them. We will go to each one step by step. Okay? So this is just for your reference. If somebody wants to understand the importance of the flow of the pressure volume loop, you just keep on these points. Now the flow volume loop. So this is it is the same like the pulmonary function test, but in the opposite way. So it means that you start up, then go down. In the pulmonary function test, you start from down, goes up. So it's the same idea. So you start by the flow, because we are relating the flow to the volumes. You start by the flow in the expiratory time. Start by 0, go to 0. Then the expiration, the flow of expiration. This is the peak expiratory flow, then go back. Okay? So this is if you relate it to the flow waveform. So this is the peak inspiratory flow. Then this is when it's coming down till inspiratory time is finishing. Then when the expiration starts, so this is the peak expiratory flow. Then it will come back to the 0. So the importance of this flow volume loop is mainly for the resistance. So if there is a problem with the resistance, if there is a problem with the obstruction, this loop will help you. Okay, now we will go to the clinical application. So we just describe it. We just describe the waveforms. We just describe the loops. Now we are going to understand what's going on. So these are the things which are going to go through it. Short eye time, leak, air trapping. So we'll go all of them now. So let's talk about inspiratory flow not reaching zero. Okay, so we said that the normal, in the flow waveform should start by zero and go down till we reach the zero. So when it is not reaching zero, what does it mean? So we said that expected if it is pressure support mode. If it is not pressure support mode, this means that either there is short eye time, as we said, means that there is good compliance, high compliance, means the lung is improving. You need to give more time for the lung to get the flow, to get the volume needed, or there is high pressure, so high resistance. Sometimes if there's secretion, if there's kink tube, so this means that you need to give more eye time. So, or there is the pathology of the disease itself. In case of meconium aspiration, we need to give more eye time. Or if there is leak, so if the flow continue to go out, so it's going out, whatever you will do, this means that it is leaking. So here you need to check if there is a problem that the eye time is not reaching zero. These are the conditions you need to look for. Okay. So if you see this graphs here, what do you think? First of all, you need to make sure, is it from the beginning, is it pressure support mode or not? Now, if you didn't put it as a pressure support mode, then you have to look for other things. So in this case, because there is another trick here, that the volume, the expiratory volume is not reaching zero. This shouldering here means that it is leaking. So here, the example, it is the leak. Okay, so short eye time due to leak. Okay, so this is the way it looks like. The problem when there is a leak in the flow wave, when you see it in the volume, as we said here, when there is a leak in the around the ET tube, this is a problem that it can generate because the leak means that the air is not reaching to the baby properly. So means that there is less volume reaching to the baby. It can cause a problem that if you are putting the baby on volume guarantee, let's say that to control the volume, then you cannot deliver it properly, because if there's too much leak, then you can't put the baby on volume guarantee. And the major problem here that the flow sensor may pick up this leak as a trigger to the ventilator. So the ventilator may start auto-triggering. So this leak is a major problem. When you see it, you need to try sometimes to adjust the position of the baby in a way that like some sort of flexion on the neck. Sometimes putting the baby on prone position with, in a way you can adjust the leak sometimes. Now there are machines which can compensate for the leak around 20–30%, not more than this. Now, if the leak is too much, sometimes you are forced to change the tube, because no way that you can ventilate a baby with too much leak. Again, where you can see the leak, you can see it in the pressure volume loop. So as we said, it should start by the pressure should start from the peak, go up and reach down. Now, if it didn't reach down, this means that there is leak here. Okay. The same thing, you can see it in the flow volume loop. So the flow volume, it should start from 0, come back to 0. And in the negative deflection, the expiration should come back to 0. Now, if it come back earlier, this means that this is leak. Okay. So now we know the leak, how it look like in the flow waveform, in the volume waveform, and in the loops, the pressure volume and flow volume. Again, the same. So start by peep, come up and come down. So this drop here means that there is leak. Again, the same. So it reach to the line here before reaching to the 0. It should be reached to the 0. So if there is a gap like that, this means that there is leak. Now, in case of short eye time, we said we give the examples. So if you have higher confidence in improving ARDS, so the line will not, the flow wave will not reach the 0 here. And this means that you don't give enough eye time. You don't give time to the ventilation to give the needed volume. You don't give time to ventilate the baby. So you lose the volume by giving short eye time. And this can be described easily from the volume time waveform. So the volume waveform, so this is if you give proper eye time, so you give proper wave, you give proper volume. If you reduce the time easily, you reduce the volume. Okay? So this is if you have high compliance, if you remember the time constant formula. So if you have high, the compliance multiplied by resistance. So if you have high compliance, you need more eye time. If you have high resistance, in case of secretions or meconium aspiration or bronchospasm, then you need more eye time. Now, another problem. If you have expiratory time which is not reaching 0. So the first one was the first problem we mentioned is the short eye time. Eye time is not reaching 0. Now, what happens if the eye time is the expiratory time is not reaching 0? So here, it's stopping here, and you initiate the inspiration from this point. So what does it mean? So the air is coming in. The air is coming in. Then it's coming out. Before the full air is coming out, you'll start another inspiration. Then what does it happen? What happens? There is more volume inside the lungs, more air inside. So air trapping. Air trapping, we call it autopeep. So if you have this problem, you are going to create overdistension, autopeep, and real problem with the baby, with the ventilation. Okay, so this is one example. Other example, if you have high resistance. Okay, so high resistance, so this is the air trapping. So air trapping, we said that the air is not coming out, so it is trapped inside and we cause autopeep. So how to improve it? By decreasing the rate. So you decrease the rate, you give more expiratory time. So the air which is still in the lung, it will come out. Increasing the I time on the expense of the, increasing the E time, the expiratory time, on the expense of the I time, because the respiratory, the breathing cycle is composed of inspiration and expiration. So the ratio, the IE ratio. So if you reduce the IE ratio, means you increase the E time, this will give more time for expiration. If there is too much flow, inside the circuit, if it is, especially if it is manually set, this is again, it can cause air trapping. And consider increasing the PEEP. Sorry, this is typing problem. Increasing the PEEP. Sometimes when you increase the PEEP, it can sort out the problem. So this is what happens if there is air trapping. This is the flow volume loop. So if the air is coming in and it's coming out, but it is not reaching. So in the first example, in the case of leak, it stopped here. But if it is, you start the inspiration before the expiration and coming out fully, so still there is air in the lung. So this is the way it looks like. So this is again air trap. Now, the other problem, so this is if you give short expiratory time. So there is another problem if there is obstruction, means that the air is not coming out easily. We mentioned that it should come out fast. We call the peak expiratory flow. Then it will, whatever air will come, it will come slowly. Now, if there is resistance, there is increased, there is sort of obstruction. There is secretion that is saying, so the air will not come easily. So instead of coming sharp like this, it will come very slowly. So in this, it happens in certain situations. So there is obstruction in the large airway, valve, endotracheal tube obstruction. If there is a bronchospasm, or if there is secretions. So this is a good indicator to the nurses, especially when to go for suction. So if you see that this line is not clean, it is really ugly, or the shape of it is like going very slow to the baseline. Okay, this means that there is some obstruction, and this is the time. This is the time you need to do suction. Okay, this is again, you see it where in the pressure volume loop. So as we said, so this is the compliance line, and from the compliance line to the loop itself, to the inspiratory loop, to the inspiratory limb. So this is the inspiratory resistance. And this one, from the compliance line to the expiratory loop, expiratory limb, means this is the expiratory resistance. So if this one is also wide like this, means that there is some resistance during expiration. Again, you see it in the flow volume loop. So go in without problem, then we will go out, there is resistance. So it should go in this way. But because of the resistance, the air is coming very, very, very slow. So as we said, this looks like the pulmonary function test. So this can be due to secretions, as we said. We call it scoop out pattern. Or if there is a bronchospasm. So it's coming out in difficulty. So this will help you in case of let us say bronchospasm. So how it look like this, there is some airway resistance. So you realize you can examine baby clinically, you feel there is some wheeze. So you understand that the baby is having bronchospasm. Give him the bronchodilator. So you check the response to the bronchodilator. So this is the beauty, one of the very important benefits of the graphics, the response to treatment, especially the bronchodilators in bronchial asthma patients. So before giving the bronchodilator, how the expiration taking time, the peak expiratory flow is short. When you give the bronchodilator, it improves, and the expiration didn't take that much expiratory time. So it will end up by shorter time. Again, the same, but this time in the flow volume loop. So this is the normal. This is in case of bronchospasm, and this is after the response. Improving in the expiratory peak and expiratory flow. So if there is increased resistance in both inspiratory and expiratory, this is, we call it hysteresis. This one, it happens sometimes when there is a kinking in the ET tube, or in the adult patient, if he is biting, the patient is biting the tube. Okay? So there will be increase in the inspiratory and expiratory level. Now, the compliance. We said that the compliance is related to the, in case of the, as example, the respiratory distress syndrome of a preterm baby. So as we said, as we give it as an example, the old and the new balloon. So if you have a baby who just born, he's having surfactant deficiency, he's like a new balloon. You need very high pressure to open up the lung. Then you get very less volume with very high pressures. So with the same PIP, you get low volume. This means that poor compliance. So the compliance curve, or the compliance, what we call it, the compliance line, will be going towards the right side. Now, when you give the surfactant with the same pressure, the compliance is improving. Why? Because you start to open up the lung easily, the compliance start to improve. So the compliance line will start to go up, so shift to the left, and means that with the same PIP, you can achieve higher tidal volume. Now, what is the importance of this to understand it? So this is how it looks like. Now, if you put a VG, volume guarantee. So this is the importance here. If you put a volume guarantee, there will be some auto weaning. Why? Because with the time, you give the surfactant and you control the volume. So with the time, because the compliance is improving, you have to achieve that tidal volume, which you set it as a volume guarantee. You need less pressure. Why? Because the compliance is improving. So means that when you put the volume guarantee, With the improvement of the compliance, you are automatically weaning the baby from the pressure. Okay? So this is the way. So initially you give the surfactant, it will be very bad, then it will start to improve. If you put the VG, the pressure will automatically go down the required pressure you needed to achieve the set tidal volume, or the volume guarantee you put it will be less with the time, with improving of the compliance. Now, one important aspect is the overdistension. So from the pressure volume loop, we said there is opening pressure, maximum opening pressure, then there is a closing pressure. Opening pressure, again, just to emphasize on it. So initially, the machine is giving very high pressure, achieve less volume till you reach the opening pressure. When you reach the opening pressure, you need less pressure to get more volume till you reach a certain stage, a certain point. In this certain point, you give more pressure, but you don't achieve much of the volume because of overdistension, overstretching. We already reached the lung is already full of air, so you cannot open it up more, you cannot inflate it more. So you start to have what we call it peaking. Okay, so peaking is an indication that you reach high pressure. So in the peaking, you can actually check it in the pressure volume loop. You can check the time of the pressure you reach the maximum pressure point, and you start the overdistension in a way to reduce the pressure, reduce the set volume if you are putting him on volume in the VG. So you decrease the pressure needed to avoid overdistension and injury the lung. Okay. So how the ventilator is calculating that from C 20 over C, or compliance at 20%, divided by the compliance itself. Okay, so if it is it should be actually less than 0.8. If it is more than this means that there is overdistension. So this is, you get it as a numbers in the ventilator, in the measures. Now, if you have air hunger, so if you have this figure of 8 shape, means that the baby is himself creating the flow. Okay, so the baby himself is creating. This means that you are not giving him the enough pressure he needed. There is no enough flow of air going to the baby. So if you see the figure of 8 in the pressure volume loop, this means that you have inadequate flow. This means that you have inadequate ventilation, and this is indication of increasing work of breath and air hunger. Again, the same. So this is another, let us say you put a baby on SIMV and you set him on rate of 20. Baby is breathing 70, and you are not giving him on top of the SIMV pressure support. So this means that the baby is, you give him only this pressure, which helps him, but all the time he is in air hunger, increased work of breath. So the figure of 8, or this waves in this loops in this way, this means that it is inadequate rate. Again, the air hunger or the problem, it can happen if you have
Can I
inadequate
interrupt you, Dr. Ahmed?
trigger, inadequate
Can I interrupt you?
sensitivity. Inadequate sensitivity, what does it mean? So usually in the when you set the ventilation, you set the sensitivity, let us say especially in assisted control. You set the ventilator, you set the trigger of the machine. What does it mean? Means what is the sensitivity that I need to generate the breath cycle. So how much I need to sense the baby to generate a breath cycle. So is it high sensitivity or low sensitivity? Means that let us say in low sensitivity means that the baby has to create a lot of effort to initiate the ventilation. But if it is high sensitivity means that it picks up the smallest effort of the baby to start the ventilation. Now, the optimum way is to have synchronization. So if the baby generates some sort of effort, the machine has to pick it up to initiate the ventilation. Now, if this sensitivity is, you set it very low, so the baby will try to breathe, but unfortunately, you are not supporting it by the machine. So again, you will end up by the figure of 8, which is again air hunger. Okay? So when there is a problem with this air hunger problem, figure of 8 or going in this way, you have 2-3 things to think about. Either you have less flow or less volume, less inspiratory time, less rise time, trigger sensitivity, or the rate on SINP. So these things you have to keep in mind if you have a problem with air hunger or increased work output. This is very common in the auto cycling or auto triggering. So you come to the baby, especially if he's on assisted control, you see that he is very fast rate. You check it on the measures, especially in the old Draeger ventilation, the baby log, you see that he's having auto triggering. You see the rate it is 100, 120, 130. So this can be due to leak. And if the leak it triggers the ventilation, means you are setting the trigger on low sensitivity. Sorry, on high sensitivity. So it's picking up any airflow. So if there is a leak, this can be picked up by the machine and initiates more and more ventilation cycles. So if there is auto triggering, it can be due to leak. Okay. Also, if there is water inside the circuit. So if there are types of circuits, unfortunately, doesn't have the wires, the heating wires inside it. So it causes condensation of the humidity inside the tubings. So when it happens, the water inside the tubings, it starts to move with the flow of air inside it. Now, this flow of water can trigger the ventilator to initiate unnecessarily breath cycles. So this is again another problem. So the causes of auto cycling or auto triggering, it can be related to the condensation in the ventilation circuit, or it can be in the leak. Now there is a third example is in case of extubation. So the machine, whatever it's giving, it's not reaching to the machine. So the machine will continue on trigger, trigger, and trigger, and trigger. So this is the case if you have auto triggering. If you come and see like this shape in the flow waveform, this means that you have to look for these 3 conditions. Okay, now how to differentiate between a leak or extubation? Is it simple leak, like 30–40%, or it is really extubation? So in the leak, you are achieving the pressure. So the ventilation is achieving the pressure, but there is some leak. Now, if it is extubation, there will be a problem that all the leak, it can be 100% leak. So 100% leak means that you don't ventilate. This means that it's already out. So you have to keep this in mind. So no expiratory flow. So it is just inspiration, inspiration, inspiration. So no expiration. So this means that it is extubated. It's different from a simple leak. Okay. So again, here, see the inspiration, how it goes? It goes in this direction. So it's not coming back. So this is, again, extubation. So continuous flow of air going without coming back. So this is doesn't happen except in extubation. Now, if there is turbulence, as we said before, this means that there is secretions or there is some condensation in the tubings. Again, turbulence, secretions, the same thing in the pressure volume, in the flow volume. So this is secretions. So this is the time you need to do the suction. So, and usually we instruct the nurses, especially in patients who are having pulmonary hypertension. So in pulmonary hypertension, you need to have minimal handling. You don't need to touch the patient. Leave the baby alone. So the nurse will come to you when you will do suction. Do suction when you feel that there are secretions. How do you know that? From the as we said here. So there are all of it. So if there's moving in this way, the flow, it's not a clear line. So this means secretions. I'm trying to go fast a little bit. Okay. So I think we will give 5 minutes, Dr. Yahya, if you don't mind, before going to more examples. If we can give 5 minutes.
You want to go for like questions or you want to have a rest?
Give it as a rest for 5 minutes, then we'll go back because what's coming is very interesting. I need the people to concentrate on it.
Okay.
Is it fine?
Yeah, I'm totally fine. We'll give them 5 minutes. How long you will take my time? More time?
No, not that much. It's more, almost maybe 10–15 minutes more.
Okay. Okay, go and drink some water and come back.
Thank you so much.
Okay. Thank you very much, Dr. Ahmed. Meanwhile, if somebody has any question until Ahmed comes back, I am happy to answer.
Dr. Yahya, I'm ready. I don't know
Yeah,
if you want.
go ahead, please.
Okay. So I know that this is a very condensed informations. We are giving it within 1 hour, 1.5 hours almost. I'm just going to give you a very important practical tool. So in case of acute desaturation, we know that we check the DOP, means if there is a tube displacement, if there is obstruction due to mucus plug or too much secretions, if there is a pneumothorax or there is equipment failure. So, but how to pick it up by the graphics? So let's take a journey. So we need to go back again to the ventilation diagram so to emphasize on certain things. So we said that the job of the ventilator, the main issue of the ventilator is to generate pressure. So if you are not achieving the pressure, this means that there's a problem with the equipment. So let's agree on this point. So if you have a problem with the pressure, so you are setting a pressure, you are not achieving it, this means that you have a problem with the ventilator. Either the ventilator itself, or there is, let us say, tube disconnection before the baby, before the flow sensor. Okay? So this is one aspect. Now, you are achieving the pressure, but let's say that there is a problem with the flow. So it is related to the patient himself. So let us say there is an auto trigger, as we said. There is the air is going, it's not coming back. So you check it from the flow sensor. So if there is a problem, then you are thinking about extubation or kinking of the tube. Okay. Sorry, extubation. I'm talking about extubation. So if the tube here, if there's a problem. So we mentioned about displacement of the tube. Now, let's go to the flow. So if you check the pressure waveform. Are you achieving the target? If you are not achieving the target, this means that there is an equipment problem. What happens sometimes, the nurses, they are busy when they are putting water to the humidifier. By mistake, the tube is disconnected at the side of the humidifier. So the baby will desat. Okay, this is the example, very good example of the equipment failure. So you are not achieving the pressure set in the waveform. So the waveform is just flat. Now you go to the flow waveform. If you see that there is auto-triggering, continuous flow, this means that extubation means displacement of the tube. Now, so this is displacement we talk about, equipment we talk about. Now, if you check the flow wave and you have lack of flow, what does it mean? The flow should come up, as we said, to 0 and come down. Now, if you see that the whole waveform is small, there is a lack of flow, there is no flow going inside to the baby. So either there is sudden decrease in the compliance. Sudden decrease in the compliance, either it is pneumothorax, so there is something pressurizing, you are not able to open up the lung, or there is migrating ET tube. So the ET tube is going to one lung. Okay, so this is a problem with the compliance. It will cause lack of flow. Or there is increased resistance. Increased resistance, you will have very short eye time. So the eye time is going and not coming. You see very short eye time. How come? It was initially proper. So this means that either kinked ET tube or there's thick secretions is blocking the ET tube. So let us give examples. So here, what is the situation? If you allow Dr. Yahya, the people to talk, what is the situation?
Well, anybody can comment.
So this is, we described it before. This is an auto triggering. So the air is going in the inspiration, is not coming in the expiration. Again, the same thing. Inspiration, continuous flow. What does it mean?
Well, there is some disconnection. There is some disconnection. There is no disconnection. Extubation.
Exactly. The baby is extubated. So this is a tube displacement. So from the graphics, you pick it up without even checking the baby. Of course, you need to check and make sure the air entry, check the air entry, disconnect the baby from the ambu bag, try to check the air entry. So this is very easy way. So this is extubation. Now, if you have loss of flow, so very small flow here, what does it mean? So either, as we said, either it is reduced compliance or increased resistance. So if there is decrease in the compliance in case of pneumothorax or migrating ET tube. So, or in this case, you have thick secretions. If there's increased resistance, it was not there, it was coming down nicely. Now it is coming very steep. So this is increased secretions. Sorry, this is the case of the pneumothorax because of the loss of the flow. And this is the situation you have the secretions. So that's it. I finished my lecture. I don't know if you have any question. Thank you so much.
Thank you very much, Dr. Ahmed. I was very pleased and surprised and very happy for your presentation. Very informative, very well done, very nice presented, very informative, very controlled. I mean, I can continue for hours. Very nice, well done. Thank you very much. Great. So any question?
You can, please, you can unmute yourself and talk, please, so we can discuss whatever you want.
Okay, so people are telling you thank you.
Thank you so much.
No questions. If they have no question,
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Alaikum assalam wa rahmatullah.
Yeah, nice to hear you, Dr. Yahya. Dr.
Oh, Jamil, how are you, sir?
Alhamdulillah, bi khair. Thank you, Dr. Ahmed. Fantastic.
Thank you very much.
Even though I don't have questions, I really appreciate. I think we should keep doing this. I think in many topics.
Thank you so much, Dr. Jamil. Thank you. Thank you for
very good presenter. So, any question?
Maybe others can ask.
So I'm going to ask questions. So Dr. Ahmed, do you make changes only looking at the graphics and loops, or you do blood gas?
It's a tool. So you have the graphics. It helps you a lot in understanding what's going on with the baby. And of course, it is a tool. It's like the blood gas. It's like, so it's another tool to you, which it's reflecting what's happening, what's the interaction between the baby and the machine. So sometimes actually now with the new, there are new ventilators, you can even check the ETCO2, means the end tidal CO2, which the machine itself, it will give you a number of the CO2, which is coming as a measure. So the
Well,
technology is improving actually.
Dr. Ahmed, well, I might not agree with this CO2. The reason is CO2 detector or anti-DACR is two types. It's either mainstream or side stream.
Yes.
Mainstream will increase resistance and the side stream will increase the dead space. So it might be helpful. It might use a double port, which means increase the size of the ETT. So it might be helpful in term baby, but in preterm baby, I think the end-tidal CO2 is very limited help. So
Exactly.
need to be careful. So I have a question for you also again. Do you think that we should teach the nurses the loops and graphics and ask them to do some changes or no?
Actually, I have mentioned that. So especially in the pulmonary hypertension patients, I used to tell them, please check, as you know, that we are putting our patients who are in nitric oxide on the SLE ventilator and which is connected directly to the INO. And the SLE, which we have, it's really giving very nice waveforms. So I'm telling them always, please have a look on the graphs, have a look on the waveforms, have a look on the graphics. If you see that it is really having this ugly shape, this is the time you need to do the suction. So don't just go routine and suction the baby, unless if the baby is having desaturation, of course, or if you have this this type of waveform. So it will help a lot. Of course, when you have a proper, let us say, the new generation of the ventilators, there's a lot to work and to understand and to learn with the time.
Okay, so again for the figure 8 in the loops,
Yes.
that means you are putting a pressure support and you're probably giving very low rate. So I think the solution not only increasing the rate, but sometimes your rate might be right, but you're not sedating your patient, or your patient does not even need intubation. So
Yes,
when you have a
if
figure
he's
8,
on
not
pressure
only
support, yes. If he's in pressure support,
yeah,
and the
so either
baby,
sedate or extubate.
yes, agree with you totally.
Yeah, that's my comment on the when you have like a figure 8 or you have machine delivery
So
support, but the baby is trying to breathe by his or her own, but the machine is not giving the time due to poor set parameters. So you might be, your parameter is okay, you need a sedation to prevent the baby from breathing, such as, for example, if you have a surgical patient and you don't want to extubate, or you might only have to extubate. You don't need to sedate or increase the rate. You just maybe need to go out of the ventilator. Yes. Okay, thank you very much. I'm going to record this, of course, record it. I'm going to send the link soon for anybody who want to listen to your talk again and again. Very informative. So for this presentation, I will give you an offer. We'll discuss it later, but I am very impressed, and I think you are very good. You are a very good teacher. Thank you very much.
Thank you so much. I appreciate it, Dr. Thank you so much. Thank you all. Hope you enjoyed.
Have a good day.
Thank you so much.